Hello everyone, I'm Liam.
Chris George.
John Pankowski.
We'd like to present to you guys a case involving a 24-year-old woman with AIDS co-infected with tuberculosis, along with progressive cough, dyspnea, and wasting. So our patient, she was single with no children. She lived in a poor community in KwaZulu-Natal, South Africa, right here on the coast of South Africa. And a quick note to make is that the hospital that she was admitted into is actually affiliated with Mass General Hospital. And residents in internal medicine from Mass General participate in clinical and educational services as a part of their global health elective. In addition, she was unemployed. She had no history of alcohol or drugs or no family history of tuberculosis either. In her medical history, she had no allergies. She was hospitalized for 4 months in the previous year, and this actually made it challenging down the road because in her resource-limited area, they did not really keep a good, solid record on her medical record, so it made it challenging to treat her condition down the road. In addition, she was also diagnosed with tuberculosis 7 months earlier at another facility in South Africa, and there she began her anti-myobacterial therapy in accordance with DOTS, which is the recommended approach to managing and treating tuberculosis. And there she was on 4 medications: isoniazid, rifampin, ethambutol, pyrazinamide. These are all first-line drugs for tuberculosis, which Chris will get into later. She also tested positive for HIV, and her CD4 lymphocyte count was 102 cells per cubic millimeter. And to put that in perspective, the normal range is from 500 to 1,500 cells per cubic millimeter. In addition, her cough persistence, she developed dyspnea and reported fevers and weight loss, which is likely a result of her AIDS. In addition, on her arrival, she appeared alert, but at the same time she was starving, weak, and she was in respiratory distress. Her temperature is 40 degrees Celsius, which is 104 degrees Fahrenheit, so a very extreme fever. And she also had a high heart rate of 132. In addition, she had pale mucous membranes and conjunctivae, and also bronchial breath sounds were present in the left upper lung fields, along with wheezing in the right lung, another sign of respiratory distress. And there's also bilateral pedal edema, which is essentially accumulation of fluid in the lower extremities, resulting in swelling. So here is a radiograph of our patient, and as you can see here, there's a slight shift of the mediastinum to the left, along with opacities in the left lung, along with pleural thickening or like scarred, or it could also be pleural effusions, which is fluid buildup. In addition, she also has focal consolidation in the right upper lung adjacent to the minor fissure. And these are all indications of some sort of lung infection, most likely tuberculosis. A differential diagnosis was made by Dr. Douglas Wilson. And this is not our patient, but this is just an example of pneumocystis pneumonia. And there's the appearance is very similar to that of the radiograph of our patient. The mediastinum is shifted. There's a loss of volume in the lung, along with some pleural thickening on the left there. Another differential diagnosis, he also included 2 acid-fast species, or acid-fast bacilli, that can show up positive on a sputum sample. And Nocardia is a genus of weakly staining gram-positive, catalase-positive rod-shaped bacteria. Some species are non-pathogenic, while others are responsible for nocardosis. And in addition, Rhodococcus is it's pretty similar to Nocardia in terms of what it does. And lastly, the final diagnosis is extensively drug-resistant Mycobacterium tuberculosis infection in a patient with HIV and AIDS. And these are the lab results 3 months after her unfortunate death. And as you can see, she was resistant to many of the first and second line drugs of tuberculosis.
So how did they attempt to treat her? On day one, they started her on intravenous medication, amoxicillin clavulinate, with a crystalloid solution to keep the IV isotonic with her blood. Amoxicillin is a penicillin-based antibiotic. She was also started on trimethoprim sulfamethoxazole and vitamin B6 orally. And rifampin and isoniazid were continued because of their importance in combating TB as the first-line drugs. On day 8, she was finally transferred to a respiratory isolation ward, and she had an IV medication change. The amoxicillin was replaced with gentamicin and ceftriaxone, both of them being other types of antibiotics. Over the next 2 weeks, her condition worsened, including chest pain that radiated into her right arm and neck, continued difficulty breathing, a fluctuating temperature up to 104 degrees Fahrenheit, and a lot of weakness. And she also developed oral thrush, which is a type of basically a yeast infection of your mouth of the variety Candida albicans. So then ceftriaxone was discontinued and oral fluconazole was begun. It's an antifungal. It was meant to combat the oral thrush that had developed. On day 19, they started edema treatment for her left leg as it started swelling with fluids. They started her on enoxaparin, which is an anticoagulant, and they also scheduled non-invasive venous studies of her legs. Unfortunately, those studies were never done because the next day, after appearing confused and having significantly worsening dyspnea, she finally died on her 20th day of treatment. So what could have been done to correct this? First of all, patient should have been moved to isolation sooner. If you remember, she wasn't moved to a respiratory isolation ward until day 8. She should have been put in one almost as soon as she got to the hospital. When you're dealing with tuberculosis, which spreads as it does and also requires a lot of concentration to treat, you need proper conditions to do that. And when a patient is co-infected with HIV like ours is, you run the risk of her contracting another disease if she's not isolated. And with HIV weakening the immune system, that can be very deadly. Now, it is understandable that this wasn't done. As we said, the area is very resource limited, and in fact, isolating her could have made treatment more difficult because of how limited resources are. But, of course, there were other flaws in the treatment. Heparin prophylaxis in non-ambulatory medical inpatients. What's that? Just remember to keep her on an anticoagulant if she can't move around or isn't going to be moving around, because you don't want to develop blood clots in your legs because you will not be using them. And there is cause to believe that her immediate cause of death was actually a pulmonary embolism resulting from thrombosis in her deep vein thrombosis in her left leg, the one which was edematous on her second to last day of life. And the evidence we have for this is her confusion, the significantly worsening dyspnea, and very high levels of C-reactive proteins, which are markers of inflammation. She also should have undergone culture and testing for drug susceptibility of her TB long before her final hospitalization. If your smears are persistently positive with tuberculosis for greater than 2 months, when you are started on therapy, you increase your risk of the strain developing into multi-drug resistant tuberculosis by 12 times. And she also should have been started on antiretroviral therapy. As we said, she was co-infected with HIV, and because HIV weakens the immune system the way it does, you want to try to counteract that, especially because, and since TB and HIV working together are such a deadly combination, it's recommended even without the reduced CD4 plus T cell count that was found in the patient, just to make sure that you don't run the risk of an HIV co-infection.
So we say that her final diagnosis was extensively drug-resistant tuberculosis, and this is different from completely drug-susceptible tuberculosis based on the drugs that it is that it has developed resistance to. So extensively drug-resistant tuberculosis is resistant to first-line drugs, rifampin, isoniazid, which are the most tolerable by patients as well as the most effective at killing tuberculosis bacteria. It's also resistant to at least one fluoroquinolone and one second-line injectable. Both categories are second-line drugs, so they're less tolerable and less effective at killing tuberculosis, but the fluoroquinolones are the most important type of second-line drug. Rifampin is a very important drug in the treatment of tuberculosis because it is the only sterilizing agent. The WHO, the World Health Organization, estimates that a quarter of the world's population is infected with latent tuberculosis, which is tuberculosis that isn't metabolically active. So people who have this, they don't show any symptoms, they can't transmit the disease, but it could develop and they could develop tuberculosis. So rifampin is the only drug that can kill metabolically inactive bacteria, so when you develop resistance to that, it can be a very big problem. And isoniazid is just the most important bactericide, so it's the most effective at killing tuberculosis. So these strains of tuberculosis, at one point, they were all completely drug susceptible, but they developed resistance through two major things, patient noncompliance and physician error, through not finishing tuberculosis treatment or an inadequate treatment plan. And once these bacteria strains are exposed to a drug and not completely killed by it, they have the ability to genetically mutate and develop resistance. So once they are drug resistant, they're still just as transmissible as completely susceptible TB, and nosocomial or transmission in a hospital ward is a huge problem, especially in a resource-limited area like South Africa, and especially among a high population of patients with HIV and AIDS. So of people with XDR TB, the greatest risk factors of mortality are co-infection with HIV because of their weakened immune system, as well as the degree to which their strain is drug resistant. So over here on the right side of the slide is a graph. It was a retrospective study done of patients in South Africa with extensively drug-resistant tuberculosis. And of 139 patients tested, 98% were co-infected with HIV, and 111 people died. That's an 80% mortality rate. And most of these people, as you can see on the graph, died within 60 days of a positive sputum smear for XDR-TB. So for that reason, beginning antiretroviral therapy or treatment for HIV is key to a good outcome. So that's another part of creating a good treatment plan for XDR-TB and HIV co-infection. The WHO recommends DOTS plus, which is directly observed treatment, short course, and the plus just implies that you will perform drug susceptibility testing to determine what drugs can kill the tuberculosis, and the use of second-line drugs. Another key part, like I said before, is starting ART as soon as possible, just to bolster the patient's immune system. And once you've identified that it is extensively drug-resistant tuberculosis, after running drug susceptibility testing, doctors recommend 4 to 5 active agents that will kill the bacteria, and plus 1 second-line injectable for 6 months that it's not resistant to. And then after that 6 months with the second-line injectable, they recommend the 4 to 5 active agents for another 18 months. And over here this is just a graph showing the first-line agents on the top and the second-line agents on the bottom. And as you go down the graph, you decrease in effective killing. You decrease in the ability to kill tuberculosis and decrease in the tolerance that the patient can withstand these pharmaceutical treatments. So, like our patient was in a resource-limited setting, this comes with a whole host of problems. Another case study I'd like to bring up is the Gala Ferry disaster, which is another province in South Africa. And the disaster occurred at a clinic where 53 people were identified as having extensively drug-resistant tuberculosis. And of those 53 people, 52 died within 2 weeks. Again, about 98% were co-infected with HIV. And this is due to some clear clinical limitations. At this point, doctors in 2005 didn't have a solid idea of how to treat or deal with XDR-TB, but also the clinics they worked in had poor isolation practices. They didn't require people to wear masks, They have poor air ventilation because they don't have the facilities to accommodate negative pressure rooms, which just allows air to come in and circulate, but infected air not to escape. Lab limitations are another big part. The second bullet point here under that tab is that they often don't perform drug susceptibility testing or can't get it back quick enough, and that's the biggest obstacle to treating extensively drug-resistant tuberculosis. Oftentimes it takes up to 68 days and even longer in our patient. It took 3 months to get those results back, and often patients die before that. Also, they use sputum smear microscopy, which they'll analyze the sputum under a microscope instead of developing a culture from the sputum. And culture testing is more effective at identifying tuberculosis, but it's harder to do and costs more money and takes more time. Also, another part of this is second-line drugs are expensive and limited. Oftentimes in resource-limited countries like South Africa, these are controlled because unregulated use of them can lead to a strand that's further drug-resistant and even more potent and harder to treat. So this leads us to ethical questions. Should we as a society spend a lot of money and resources and time to treat people who don't have a good survival rate, don't have, they're poor, they don't offer a ton to society? But in our eyes, the answer is simple. It's yes. We have a responsibility to take care of people who can't take care of themselves. But as a society, we need to face the fact that we are moving away from antibiotics, and the age of antibiotics might be coming to an end. Thank you.
Questions?
I was wondering why vitamin B6 was used originally. I thought that was kind of interesting, like one of the original treatments.
Funny you ask that. Because vitamins are good for you.
You want me to answer that?
I don't know if you know that.
Yeah, I mean, B6 is going to support cell division, right? Yeah, cell growth. And so it's really just when you have a low CD4 plus count, you want to make sure that they have all the tools to try to keep that up. She probably was nutrient deficient anyways in the country that she was at, or the region that she was from. I'm assuming that's why that was administered. Yeah. Any other questions? Yeah, there's a bunch of questions I could ask here that were interesting. It's a really interesting case. It's an important case. I didn't comb through the paper. Was there any indication of how she got HIV?
There's no indication.
Yeah, nothing really.
She was like 18 or something?
24.
24.
She had been hospitalized 4 years previously.
Okay, so she's probably had it for a while.
Right.
Yeah. Why did she develop thrush?
We're not sure. Probably just
Take a
poor
stab.
isolation, poor ventilation, poor isolation.
Maybe. Yeah, the poor ventilation is what's going to spread tuberculosis. So what? Take another guess.
Fluid in her lungs.
Well,
Became fluid in her mouth.
she's not ventilating properly, right? And that may contribute to it. But she first of all has HIV, so she's susceptible anyways to getting thrush, and HIV patients often do get it. But they just the double whammy of hitting her with a bunch of they started with azithromycin, then moved to gentamicin. Is that correct? It was the first antibiotics.
No, they used gentamicin. They didn't use azithromycin. They started with amoxicillin.
Oh, amoxicillin. Yeah, perfect. That's the one. Amoxicillin, and then went to gentamicin. So those antibiotics aren't going to touch the TB. They're not going to touch the TB, but they are going to kill off all the probiotic flora in this woman's GI tract, from her mouth down to the other end. So having the double whammy of HIV and just absolutely the wrong antibiotic. They didn't, and she came in, whoever she saw didn't quickly assess the situation and make the right decision. Gave her some antibiotics that potentiated the thrush. It's because she took all these antibiotics and killed off her natural flora that the yeast was able to take hold in there. Some other things. That data that you showed, the survival susceptibility rate, was that data, was there any information in there? Was it separated at all for antiretroviral versus non-antiretroviral?
There was a lot of patients. I forget, during the study, they said they hadn't done much research on the time of starting antiretroviral therapy. But it did say that starting that did increase the life expectancy of the patient. And they started that before I do remember it now, they started antiretroviral before the diagnosis with XDR TB. And one of the things they found interesting is
all 180 or whatever.
Yeah, and all 139, or all the people tested, antiretroviral was started. And it increased their life expectancy over the people who didn't get tested for it. But they didn't, so they found that starting antiretroviral therapy in patients with MDR TB, only multi-drug resistant, did not have an effect on their outcome in life. And they thought it was because in just about all of those patients, it was started after the diagnosis. Mm-hmm. So after the tuberculosis had already taken hold.
I see.
So again, starting that early is probably the best thing.
Yeah. I could ask a few other questions, but I'm only ask one that is kind of the most cutting question, I think. Is at the end you talked about the ethics of treating these patients. You appeal to our humanity, which I am obviously sympathetic to, that it is our duty to care for those who need it, right? And that's the charge of every healthcare worker. But say you are someone in the government. There are certainly people in the current administration in our government who say that the United States is spending far too much money on foreign aid, part of that being the subsidizing the pharmaceutical industry to provide a modicum of more affordable drug treatment to countries exactly like this. So to that bureaucratic administrator that is not moved by the human appeal that you make here, how do you move the ball there? Give me a different argument.
So I would bring up the point that first off bring up the point that a quarter of the world's population is infected with latent tuberculosis, and just because of how connected the world is today through transportation, flights, through sea, through air, it's just tuberculosis, especially drug-resistant tuberculosis, has a major ability to become a pandemic because it costs huge amounts of money to treat this. And if it was the problem in America that it is in poorer regions of South Africa, it could really decimate the population because we don't have subsidized health care, and a lot of people couldn't afford this treatment. It oftentimes costs well over $100,000 just to treat multi-drug resistant tuberculosis. So I would say if you don't subsidize the money now and provide help to these people, research and development to aid the problem in South Africa, it has a very good chance of, in the next, next couple of decades, spreading to America and becoming a major problem here.
Any other questions? Thank you very much.
Thank you.